I'm coming here to talk about something that I discovered relatively late in my career. I've been a practicing dentist for too long. But about 6 years ago, our new dean at Penn came to me and said that he wanted to start a clinic in partnership with a refugee relocation organization in Philadelphia, and that our patients would be made up of refugees, asylum seekers, people who had suffered some significant traumas. So that was the premise. The good news was I had about a year to prepare for this, and I went, like all academics, in a deep dive to figure out what was in the literature about trauma-informed care in dentistry, as well as what is trauma. And what did I discover? I discovered there's almost nothing in dental literature or in oral health care literature on trauma-informed care. I also learned that trauma is a very fluid description of what many of our patients experience. I think most of us as oral health care people understand that the number of adults who do not seek any type of oral care hovers around 50%. That's a truism that's been out there since I was a dental student back in the dark ages. But it remains constant. And we've gotten very complacent about the idea of fear and oral care in our patient populations, that it's almost normative. And one of the things that I started to think about and discover as I went about researching the start of this clinic and then ultimately serving the patients in our clinic is that the fear doesn't come from nowhere. It's not hardwired at birth. It does become hardwired, but it's typically generated by life experience. And so what I want to do today is, this is just scratching the surface, but what I want to do today is talk a little bit about our experience at Penn, and also talk about trauma itself, and some of the ways in oral health care that our patients bring this history and how we approach it, and then a little bit of some of the tools that we've learned along the way, and also some of the resources that I've discovered in Pennsylvania that will help in serving our patients better. So I talked about fear, and it being a learned response. So let's talk about the experience of trauma in childhood, and then I'm going to talk a little bit about the experience of an older, say, adolescent or adult. One of the things that we've learned about trauma in children is that it becomes an actual physical response. This was something that surprised me. I thought that a fearful child, and pretty much the way I was educated, was that a fearful child was either reactive to a parent's fear, or was maybe a behavior issue, or perhaps had been conditioned that way by an older sibling. One of the things that I learned is that through traumatic experience, that children's brains, which are developing, we now know, up until the age of early 20s, will actually rewire as a response to trauma. And the rewiring happens at the base of the amygdala, which then is responsible for emotional response. So that children experiencing trauma will oftentimes be very, not be able to control their response to a perceived stimulus. So what are some of the things that might cause trauma in children? Well, that's also another interesting topic. Because what is traumatic for one child is not necessarily traumatic for another. And one of the things that I also started to learn is that there are many mitigating factors to trauma. So first of all, what are the major traumatic events in childhood? They're called adverse childhood experiences. Many of you may be familiar with that term, or ACEs. Adverse child experiences are often things like poverty, perhaps an incarcerated member of a household, a household where a member is experiencing some sort of a substance issue, a household where there have been arrests, a household that has been disrupted through homelessness, a household that has been disrupted through divorce or death. So, you know, those are pretty substantial experiences. What is mitigating? So what's also mitigating is the child's support system. So we know that not every child responds to the same events in the same manner. So what helps a child? What helps a child is often just a narrative. And I'm quoting articles. If you do have, I think there are copies of the slides in a booklet. If they are, there are sources at the bottom of the slide. So please use those sources. They're quite good. But what helps in mitigating a childhood's adverse experience are things like a narrative, a teacher, or perhaps another healthcare provider or someone that the child can relate an experience to, that person acknowledges was a terrifying experience, or an experience that's ongoing. A child who's going through bullying, we're all familiar with that now. Having someone who is helpful, not necessarily in trying to reverse it, but in terms of validating it. So the common thread through supporting a child undergoing trauma is the validation of their experience. So that is becoming a significant piece in the treatment of childhood trauma. When we start to examine traumatic events later in life, we see that some of the same physical responses happen, but what happens in an older adult is the emotional reaction and it getting programmed also at the site of the amygdala in a memory piece. Rather than a neural response, this is a memory piece. Both responses, however, when triggered, result in a dump of cortisol. So that the patient who's sitting in your chair who suddenly becomes very scared or maybe triggered experiences a tremendous cortisol dump, which then can, as we all know, increase heart rate, create fear, create the flight or fight stimulus, but also in the long term, recreate that feedback loop so that the triggers that we may unintentionally provide for our patients tend to re-stimulate that whole response. So we've got this physical response to trauma occurring in our patients. And we start to wonder, okay, what do we do about that? Well, we talked about the childhood mitigating factors. In the adult or the older child, it's pretty much the same. It's a validation. But the one piece that's very significant is the lack of autonomy. Persons who are undergoing trauma or a re-evaluation or re-triggering of it tend to tell us that the biggest piece is the loss of autonomy. And that oftentimes in an adult, the whole creation of trauma in and of itself is the loss of autonomy. So certainly we go back to our early patients in our clinic at Penn, and these were dislocated people. These were people who often lived in refugee centers. These are people who many, many times experienced physical torture. These are also patients who suffered political, social, sexual, horrible experiences, and as a result came to us with all these traumas. So we are learning that the biggest piece that these people have lost is their autonomy. And bringing that to the table of treatment is significant in enabling our patients. So let me see what slides are here. This is right off the CDC's website, Guiding Principles to Trauma-Informed Approach. And what we're seeing, you probably can't see this from the back, or can you? You can. First one is safety, trustworthiness, transparency. So that becomes the honesty piece of talking to patients. Peer support, collaboration. These are all pieces that I urge you to go to that website. It's CDC. If you Google or go to CDC website and do trauma-informed care, you can click on each one of those and talk about it. But more important, in our offices, bear witness to the patient's experience of trauma. This is the piece that we talked about, that I talked about earlier, validating the fact that this patient has undergone a traumatic experience. Helping patients feel that they're safe. So in our clinic, very early on, we started to get referrals for patients who had experienced intimate partner violence. This was a significant piece, making people feel they were safe. Certainly, any of our refugees who had experienced physical trauma. As we know, in both instances, people are more likely to suffer facial and oral trauma as part of that experience. Coming to our office was significant for many of these people. They were coming only because they were desperate. And making them feel safe often took several visits. Making them feel that it was okay to be touched in the face. Making them feel that it was okay to be touched in their mouths and have things in their mouths. Include patients in the healing process. So what does that mean? What we discovered was that if we could talk to our patients about what our hopes, expectations, and goals were for healing, and how that meant our physical manipulation, such as I'm going to be touching your gums, and I'm going to be using an instrument to feel with my fingers, and this is how you will feel it. This is what it will feel like afterwards, and this is why. So involving them and including them in what we were doing, believing that they could do it. And we often would say, hey, this is what we're going to do together. This is what we're going to achieve. So motivation is very, very key. And also being very culturally sensitive to the specifics of our patients. So this article that I cite at the bottom is excellent. It's a team from Canada, and they've looked specifically at trauma-informed care in healthcare. So I urge you to read some of their work. It's quite good. So in our dental office, what did we find when we started to look at trauma-informed care? So going back to childhood trauma, one of the really awful things that I discovered is that, and this was consistent across several articles that I read just in general about trauma in children, not specifically related to healthcare, is that a minimum of 40% of children experience traumatic events. That may be inclusive of the adverse childhood experiences. It may be in addition to those. And these are children who have responded to those stimuli. There are many children who experienced childhood adverse experiences, but did not necessarily judge them to be traumatic. So, you know, you're looking at a significant part of the population of children that have had really experiences that they're bringing to your offices that are ready to be re-stimulated. A very sad statistic is that 22% of all women and 8% of all men experience sexual trauma. Interestingly, when we surveyed our colleagues as dentists and asked how many treat or utilize trauma-informed care techniques, it was well over 90% said, no, we don't. We don't do this at all. And the next question, of course, was why? And the overwhelming response was that we didn't have training, we didn't know what to do, we feel funny about talking to people, and we have no resources. One of the things that I'm hopeful for in starting some of these discussions is that we start to compare notes and that we start to help each other and train each other and get comfortable with these conversations. What we've discovered is that a significant part of our population is coming to our offices with trauma in their past. And they may not even have identified it as trauma. Go back to that statistic that's remained constant. 50% of adults don't seek dental care because of fear. We know about fear. We know that the longer a patient avoids us, the more complex their treatments are. We know that the most fearful our patients are, the more advanced their dental disease is. And yet we don't ask our patients oftentimes why they're fearful. And one of the things that we've learned is that just the dialogue with our patients is often enough to establish an affirmation for them that this is a terrifying event for them. And we can often get them to tell us what the triggers may be. Good, I'm glad this slide did make it. These are the things that we do in dentistry that are known triggers for many of our patients. Supine positions, we put people in very vulnerable positions. We put patients in very vulnerable positions and we shine very bright lights in their faces. And then we put things that don't feel or smell or taste particularly good in their mouths. And we ask them to remain passive. Go back to that statement I made about autonomy. These violate many, many of the aspects of autonomy. And so if we are cognizant of the lack of autonomy that these things are doing to our patients, mouth props are terrifying. Rubber dams, you know, even anesthesia is terrifying. Certainly needles are. And so if we start to acknowledge and discuss with our patients, these are the things that I need to do, these are why I'm doing it, this is what it's going to feel, taste, smell like, This is what it's going to feel like afterwards. How much are you willing to do today? Oftentimes, pacing things out is a real benefit to our patients. So I'm going to leave you with this pyramid. This is a group that's published in several healthcare venues. This is an article that appeared in JADA. This is the one trauma-informed care article I could come up with. It was published in 2014. I think 10 years later, we're ready for some more information. But this is an excellent pyramid because it acknowledges not only what we can do and should do, but it also acknowledges the fact that many of us bring our trauma to the practices of oral health care as well, and how that becomes a very important piece in our practices for how we can avoid the triggers ourselves. It also acknowledges the fact that when we do have our patients who we need to be very cognizant of, that when we work with our colleagues, that our colleagues are also capable of the same conversations and sensitivities that we bring to our practices. Probably, and I'll end with one little vignette, probably one of the biggest mistakes I've made in the last couple years in our practice is that we had a patient who had experienced significant intimate partner violence. It took many visits to get her comfortable. It took 2 years to treat her dental disease. And her abiding wish was to have orthodontic care. She became a wonderful patient in our practice at Penn, but when she finally was stabilized, was ready for orthodontic care, I very nicely referred her to our ortho department, and it was a disaster. And it was entirely my fault. Why? Because I referred her as I would have referred any other patient. And she was, even though she was very comfortable because of the accommodations and the trust that we had engendered, it was a completely different setting. And she was not prepared for it. I did not prepare her, and I did not prepare them. So we need to be cognizant. We need to create our conversations with our colleagues, and we need to create our own networks. Referral base, agreed in advance, provide context. This is all very important in your referrals. I did include, okay, great. Resources. These are going to be in your slides. They're really wonderful. Some are national. Some are very local to Pennsylvania. They're excellent. One of the things that you can do is start using the resources. The materials are quite good, but the conversations need to start happening in all of our midst. Thank you.